My name's Al Getgood, an orthopedic surgeon at the Fowler Kennedy Sport Medicine Clinic in London, Ontario, Canada. Thanks very much to Dimitri for the very kind invitation to be joining your meeting today. I'm sorry I can't be there in person. I'm going to be speaking about my approach to the multi-ligament injured knee. These are my disclosures. So if we see a patient like this is a young 18-year-old girl, she's a cheerleader, she has this injury. The question is, what is the best approach to manage her left knee injury? So for the next 10 minutes, I'm going to be discussing the assessment of the multi-ligament knee injury, clinical examination, imaging, and treatment, decision-making and operative techniques, and then sort of rehabilitation. So in terms of the presentation, obviously it's important to understand whether this is a history of an acute or chronic presentation, and also the mechanism of injury. When seeing a video or seeing a patient or an athlete, maybe it's a little bit easier, but of course, if they're presenting to the emergency department, you don't necessarily know all of the details. So it's important to really understand that we know exactly what's going on. In terms of the physical examination in the acute scenario, of course, ATLS protocols with life and limb-threatening injuries should be dealt with first. And then during a secondary survey, we can look at the knee. And it may be in the acute scenario not being able to assess very much apart from hemarthrosis, whether or not they have gross laxity. And of course, recurvatum is very easy to see because it may be very painful not be able to fully examine the knee. But very important to document the neurovascular status. When thinking about the vascular examination, we utilize selective arteriography with ankle brachial pressure indices, really helping us determine whether or not we need to do anything regarding arteriography with an ABI of greater than 0.9, just requiring an observation, an ABI of less than 0.9 requiring CT angiogram, and then of course a pulseless limb needing urgent vascular assessment. In terms of the neurological exam, it's very important that we assess the common peroneal nerve. Certainly, it's very common to have these injuries, particularly in the overweight, so the morbidly obese patient with the ultra-low velocity multi-ligament knee injury. It can occur up to about 45% of cases when associated with a PCL post-lateral corner injury. And we really should be looking at both the deep and superficial branches. In terms of our clinical examination, as already mentioned, we may not be able to get very much in the office. So I may not be able to get very much in the emergency department due to the acuity, but the more chronic scenarios, such as in this scenario, this is a young guy with an ACL post-lateral corner injury, we can then actually pick up a lot of key findings. And so we need to be assessing both cruciates, and then of course the collaterals, not just in the coronal plane at 30 and 0 degrees of extension, but also we also look for rotatory laxity, both anterolateral rotatory laxity with a pivot shift, as well as posterolateral rotatory laxity with a reverse pivot shift. One thing I would suggest is very, very important to look for the dial test, and the dial test does not always mean a posterolateral corner injury that is often talked about in textbooks. It really just means that you have increased external rotation laxity. And of course, it can mean that this is a posterolateral corner injury or anteromedial rotatory laxity, just like we have on the top right-hand side of the screen. This is a young man with a positive dial test, but has anteromedial rotatory laxity, not posterolateral. Our imaging, we can use plain radiographs as standard. AP lateral Rosenberg stress radiographs are helpful in the chronic scenario, as are hip knee ankle alignment films. MRI is useful to determine what is injured. Doesn't tell you the extent of the injury necessarily, or at least it doesn't tell you anything about the patholaxity. And CT scans are utilized when looking for associated fractures, or of course CTs. The MRI, even though it doesn't tell you anything about laxity, it can give you an idea about the mechanism of injury. And this is an example of a bone bruise pattern on the anterior aspect of the femur and anterior aspect of the tibial plateau on the medial side, really suggesting a varus and hyperextension type injury, and this is associated with a posterolateral corner injury. As I mentioned, we use hip knee ankle alignment films, and then in the very chronic scenario, particularly with revision ACL type cases, we use a single leg monopodal stance so we can measure tibial slope. Stress radiographs have been worked up and demonstrated very nicely by Dr. Rob LaPrade's group, showing both valgus and varus stress radiography to be very helpful to determine both the extent of medial-sided injury as well as lateral-sided injury, as well as using PCL kneeling stress radiographs to determine the extent of PCL injuries, and I use these very routinely. So once we have all of the information, then we have to make some decisions, and there are lots of things that we need to decide upon when treating these patients optimally. So first thing is operative versus non-operative. Well, this systematic review based on numbers of case series would suggest that early operative treatment results in improved patient-reported outcomes, higher rates of return to work, and higher rates of return to sport. Of course, non-operative is still an option, and we are part of a large randomized clinical trial with the University of Pittsburgh that have compared early versus delayed surgery. And some patients have actually managed to do quite well with the delayed approach with some healing. But certainly my current approach is isolated injuries with no significant corner injury, then often a PCL injury on its own can be treated non-operatively. And of course, if patients are asymptomatic, you don't necessarily need surgery. And that treatment involves physiotherapy, but also the use of dynamic support braces. In this example is a PCL support brace. And if you get these on in an early phase, in the acute scenario, we can often improve the grade of injury by at least 1 grade. Absolute indications for early surgery includes vascular compromise, compartment syndrome, open injuries, and of course this irreducible knee with a dimple sinus and incarcerated medial ligament, and must not be missed as it can be a devastating injury. We try not to use external fixators when possible, particularly if not able to hold a reduction, or that's very helpful in the obese patient. When there's a vascular injury, it's important that we use MRI compatible implants, and we try and avoid putting the implants through the quadriceps. So keep them lateral on the femur and then medial on the tibia to try and avoid quadricep, the extension mechanism. Timing of surgery, well, I've already talked about being part of the RCT. In the ideal scenario, as current evidence, and certainly my own practice, would be to try and do things at the earlier stage, less than 3 weeks, and then if we're delaying things after 3 months. But ultimately, ideally, you want to have a quiet knee with a good range of motion. In the chronic scenario, greater than 3 months, that's when the scar tissue settles and there's less chance of being able to repair structures. You can stage them. You can do things at different stages, but it really depends on the surgical approach and the associated comorbidities. So if I were to stage anything, I would do the PCL in corner first and then an ACL later. Usually I try and do everything all in one go. Lots of the debate regarding repair versus reconstruction. Number of studies, particularly from Levy and Stannard, showing 40% failure rates of post-lateral corner repair. My approach really now is to repair and augment where appropriate. So essentially any structures that can be repaired, we repair them, and then augment with a graft, and then that allows early range of motion. In terms of graft options, we have lots. You've got lots of autograft options, but of course allograft can be very helpful if you have access to it. So technical pearls. So in terms of preoperative planning, I think it's very important that you organize your thoughts, write the steps down on the board, and get everybody on the same page in the operating room. And this really helps maintain momentum and efficiency in the operating room. Examination under anesthesia is very, very important. Sometimes the examination under anesthesia, you can pick up some extra issues with the knee, and it may even change what you do. So don't be afraid to add or remove things based on your EUA and arthroscopy. I tend to do my extra articular approaches first. That involves the graft harvest and preparation. The beauty of this is that it allows dissection without distortion of tissue planes from fluid extravasation, and it's also very safe. So if you do have any capsular rents, then the fluid will just drain out of the knee rather than down into the calf, and so it reduces your risk of compartment syndrome, and also maximizes your tourniquet time if you use a tourniquet during this type of surgery. In terms of PCL reconstruction, my preference is to do a single bundle when it's a relatively low-grade PCL and the meniscofemoral ligaments are intact, whereas I use a double bundle technique when grade 3 PCLs, particularly in the case of where the meniscofemoral ligaments are lost. And this involves 2 femoral tunnels and a single tibial tunnel, as Laprade has previously described. And I'll often use a mixture of autograft and allograft. The post-lateral corner reconstruction is what I describe as a modified Laprade, so it's using exactly the same anatomic landmarks, but it's using a single semitendinosus autograft with a loop in the tibia. We published this, and it's been published on Arthroscopy Techniques, and you can look that video up and watch it in your own by yourself. and this will basically outline the key steps. But the benefit really is that we use a single one single tendon for the graft, but you can actually do an anatomic technique with both femoral and tibial and fibular tunnels. And using the same postlateral corner bony attachment as Laprade has described, and it's a relatively straightforward procedure. This has been validated. We did do a biomechanics study that showed that it was equivalent to the traditional Laprade reconstruction. In terms of the MCL reconstruction, again, my preference is to utilize a very similar anatomic landmarks as the Laprade technique, but I use a doubled semitendinosus graft with fixation distally on the tibia and then tensioning proximally on the femur with an adjustable loop that really allows us to dial in our tension. And I add in an extra anchor on the anterior limb to allow for the insertion of the proximal portion of the superficial MCL. I only add in a posterior oblique, so a POL reconstruction, if there's the absent tissue. If the tissue is present, then I do an imbrication and synthetic augmentation. Utilize exactly the same anatomic landmarks as what Laprade described. And we have shown in this double bundle SMCL reconstruction that if you place the anchor just a little bit more anterior, we can actually control anteromedial rotatory laxity better than the original single bundle, single graft Laprade technique as described here. The outcomes of this reconstruction tend to be excellent. We have published in this looking at stress radiographs postoperatively and shows that we can reestablish coronal plane laxity very nicely. Very important also to think about the use of osteotomy. So we know that varus significantly loads PCL grafts as well as ACL grafts. So if you have a varus thrust, think about correcting that in the chronic scenario. So this is an example of a failed postlateral corner reconstruction where we did a coronal plane correction on the tibia, and that certainly solved his ongoing laxity problems. Similarly, this is a medial-sided injury where an ACL, PCL, MCL, and there's a distal femoral osteotomy to correct his valgus. We can also use it to correct slope. This is a PCL injury, and we increased this patient's slope as well as correcting the coronal plane, and this actually improved his station significantly, and he didn't need any further soft tissue reconstruction. Rehabilitation is very important. The rehab goals are to protect the graft in the early phase, so we use bracing, particularly dynamic bracing when the soft tissue settle. We then want to have full range of motion by 3 months, and then continue on with strength and conditioning. We utilize this general rehab protocol to get them back to their full activities, usually by 9 to 12 months, but it's not uncommon to be 12 months plus. Return to sports are certainly not as high as what we'd like in terms of comparison to ACL reconstruction, and certainly 3 ligament tears don't do as well as a single ligament such as ACL, MCLs. As soon as you get into a cruciate or bicruciate plus corner, then the return to sport rates drop significantly. So finally with this patient, so we saw that she had the postlateral corner issues, ACL, PCL, postlateral corner, and you can see this on a clinical examination with significant posterior draw, as well as a quad active test, and then coronal plane laxity. Her MRI scan confirmed the bicruciate injury. We can see here this anteromedial bone bruise sign, as well as on the coronal, and we can see her postlateral corner injury. So she underwent early reconstruction with ACL, PCL, anatomic semitendinous autograft. At that stage, I was using 2 grafts, not a single graft. And this is just intraoperative pictures of her grafts. Some postoperative radiographs showing the tunnels being in a satisfactory position. And then her returning to her activity, she actually got back at about the 10-month mark doing these activities with the brace on. So in summary, you need a high suspicion of multi-ligament injury in the polytrauma patient. HLS, life and limb threatening injuries come first. You need a thorough vascular and neurological exam. You try to avoid external fixators. We use stress radiography to help with diagnostics. Our anatomic repairs and reconstructions, we need to be aware of multiple techniques and graft options. Don't forget about alignment. early range of motion, I think, is probably a good idea, but use bracing and good rehabilitation principles, and very important to counsel patients appropriately regarding expectations of return to sport. Thank you very much for your attention, and good luck with the rest of your meeting. I hope you have a very successful event. Thank you.